Gary.
Let me in. Hey, how are you, Karen?
I'm great. How are you?
Well, you look nice.
Well, thank you. I would you can't see the shorts that I have on.
Yeah. How was Michael feeling?
He's feeling better. He should be joining in a few minutes. Yeah, so he's right there. But we had a volunteer helping us with some of the citations on the testimony. So we have an even more updated version from what he just sent you, probably.
Oh, okay, good.
So that should, because the volunteer just was trying to add he was just trying to add a few final touches.
Yeah, I hope that's okay, Gary. I was just fussing.
It is, and keep in mind that they're recording now, so we'll get started pretty soon when Dr. Lukowitz comes on board. He's good about starting right at 4 o'clock.
Oh, great. So what we'll do then is if you'll give us a few minutes after the hearing, we'll make sure that we don't need to make any changes to the written testimony, and we'll if there are some, they will be minor. They're just updating some citations. And Karen, did Chad and Dr. Red know that they were to join us on the earlier side?
Yeah, I'll just touch base with them.
Okay.
Thank you, media services staff. We appreciate you.
Hey, Dr. McGibney, I'm here and I'll be available to start those videos that
Okay, I thought that was you, Ashley. How are you?
I'm doing well. Just
Good.
let me know when you want to play it and I'll share my screen and start the videos for you all.
Okay, Michael and Karen, this is Ashley Dixon. We couldn't do this without her. So let Ashley, Michael will be the one to let you know when the videos are to be played.
Hey, Ashley, it's nice to meet you. Should I just say, Ashley, it's now time to play, Javante Ford's video. Would that be the right cue?
Yes, you can say that. And if you're sharing your screen at that time, just unshare it so I can share, because I think one person at a time can share.
Okay. We're not planning on doing any slides, so it will only be, you'll be the only person who is using any media or anything. Okay. And okay. The first person is Javante, so he's going to speak first. And then when he's finished, I'll just say, Ashley, if you could now, queue up Miss Lanier's testimony, and then it will be Glenine Lanier, who's the second.
Okay, got you.
And Gary, Karen, Ashley, can y'all hear me okay? Is this my sound quality okay?
Yes, absolutely. And I don't know, Gary, does it probably make sense for while Michael is talking for us, I can keep my camera off and, just so it's not distracting, we can keep our cameras and of course muted, but just cameras off so that all attention is on Michael Waller.
That's your choice, your decision.
Okay.
Well, what will the folks be seeing, Ashley? Do they see just the person speaking? Is that basically what it looks like to them?
Sorry, I was talking the whole time, didn't realize I was muted. But once I share my screen, you'll pretty much see the video, and I guess whatever is recorded will play along with the audio. So everyone should be able to see the video. If the video isn't playing, then just let me know and I'll try to start it over again.
Great. And when when the speakers are speaking, so for example, when I'm speaking, just be the video of me speaking, or is there going to be this Georgia House of Representatives subcommittee slide here? What will folks see?
They'll see your face. They'll see your full video will come into view once the House Media Services unshares their screen.
Okay. Not sure if that's good or bad.
A full screen of Michael.
I know. Yeah, it's a bit much.
Can
we'll
you guys hear me?
Actually, there are going to be two other folks that join us. So there'll be Dr. Ailey Red and Chad Jones, and they will, at some point, I'll hand it off to them. They're going to do kind of a 10-minute presentation, each of them. Again, I don't think they have any media, but so at that point, they'll start talking, and it would be their image that everyone would need to see.
Okay, perfect.
Can you guys hear me?
Yes.
Yes.
Something's going on with my video, but I'm sending another message to Chad and Allie to please, there's Chad, good, okay. Hey, Chad.
Hey there, how are you doing?
Good, good.
Hi, Chad.
Hey, how are you doing, Dr. McGivney?
Just another day in paradise.
You know, that's right.
So
That's all
Chad,
we-
we're gonna start in a minute, and just as a reminder of the way this is kind of gonna go, I'll speak for about 8 minutes, depending on how the chair handles things. Just
Right.
kind of setting things up, and then we're gonna play Ford's video. Ashley's gonna help us with Ford's video, and then play Glenine's video. At that point, I'll hand it off to Dr. Red, to Ailey, and then after that, you'll speak. And
Okay.
you could really try to look at that clock to keep it at 10 minutes or so. Gary
Oh,
says
yeah.
a little bit of flexibility, but I'm hopeful that we can kind of get the main part of it done in the hour that they suggested, and then we'll be available for questions for a half hour or so, if that works for
Okay.
you. And I'll
So,
repeat-
Michael, Gary, I need to be done quicker than 10 to save questions, or all questions at the end?
That's a good question, Gary. My understanding was it was questions at the end. I mean, of course, they stop us, right? So,
Well, typically, Dr. Lukowitz likes to hold the questions to the end, but if there's a compelling question that he wants to ask, he'll jump right in.
Gotcha.
And we typically, these last anywhere from 60 to 90 minutes. So we have some time. If you go over a little bit, don't worry about it.
all right. Now we're just missing Dr. Red. Where's Ailey? Karen, has she responded to you?
She responded yesterday. She has not responded today. And I don't know if you guys can see me or not. My
She's coming.
okay.
Yeah, I can't see you. but I don't-
Yeah, my picture is gone. I'm here, but my picture is just not there. But I am here. Not sure. I left and came back, and it's still not there, so I'm not sure what's going on.
Ailey, can you hear us? Dr. Red? I can see that she's joined us, but I can't.
She's on mute. She's still on mute. There she is. Hi.
How are you?
Good, good. How are you?
Hey, Dr. Red.
Hello.
Hi, Michael. Chad.
Hey
Hi there.
there.
So Ailey, I was telling Chad, and just
They
to give
can
you
hear us on the live stream, just FYI. I'm sorry. Kate just sent us a message.
okay. So just as a review, what we'll do is the chair will start the meeting. We'll proceed. I have some introductory remarks, kind of setting things up. We'll watch Ford's and Miss Lanier's testimony, and then Dr. Red, I'll hand it over to you for your 10 minutes presentation, and then we'll go to Chad. After that, I'm going to do a wrap up and highlight the recommendations that we propose, and also recommendations that Chad and that you sent to us as well. And then we'll open it up for questions. So I've also prepared written testimony that will present those recommendations, and as exhibits, I've attached the transcripts of Ford and Miss Lanier's testimony, and then also reports, what you sent me, Chad, and then Dr. Red, I took what you sent me and put in the same format that Chad said. As a
Okay.
sort of- so folks will have that resource after the meeting. We'll distribute that immediately after the meeting.
So I will not need to cover that section for solutions or recommendations. Is that correct?
I think that the subcommittee, based on what I understand, would be very interested in that, particularly from your perspective. As
Do
a,
within the minutes that I'm allotted, or should I wait for you to prompt Chad and me for that section?
so what will happen is after Ms. Lanier's testimony, I'll hand it over to you for 10 minutes, and you should introduce yourself, and I think talk about what you do, and then talk about those solutions.
Okay, awesome.
And then we'll hand it over to Chad, and he'll do the same. And then I'll come back and wrap up and kind of list out the recommendations and summarize.
Gotcha.
Dr. Lukowitz is on with us now.
Hello. So it sounds like you've got a plan on who's going to start and then the progression. Is that correct?
Well, you're the chair, so I have a
But
proposal.
I'm very agreeable. Now, I just want to bring to attention that this isn't, last year we learned a lot about child mental health. And one of the things that we talked about was the importance of social determinants of health on mental health. And so this session today is meant to give people an opportunity to learn a little bit about how these things impact children and what's going on in our state currently. So with that introduction, whoever it's been decided is going first, let's let them get started. And so I'll does someone want to introduce whoever's going first?
Michael Waller, Dr. Lukowitz is going to go first.
Okay, and Michael, we've met before, so it's nice to see you again.
Me too. And I'm quite happy to introduce myself, so I can.
Okay, there you go. Who knows you better than you, right?
So are we ready then? Should we go ahead and get started?
Yes, let's do that.
Okay, well, good afternoon, everyone. Good afternoon, Dr. Lukowitz and the other members of the subcommittee. My name is Michael Waller, and I serve as the Executive Director of the Georgia Appleseed Center for Law and Justice. We are a nonpartisan, nonprofit law center that advances justice and equity for all of Georgia's children through law and policy reform, community engagement, and the legal representation of children. We focus our efforts on removing barriers to justice experienced by Black and Brown kids, children experiencing poverty, LGBTQ+ children, children with disabilities, and children in foster care. We believe that justice requires that every child have access to strong, nurturing schools and a stable, healthy home. So we have two primary program areas. We refer to them as school justice and housing justice. Our school justice initiative has two main strategic priorities. The first is keeping kids in class and out of the juvenile justice system. And the second, particularly relevant to today's discussion, is increasing children's access to needed behavioral and academic supports. And we focus our housing justice initiative on ensuring that low-income families have stable, healthy housing. So as we were just discussing, I'm here today to share legislative policy and best practices recommendations to better support mental and behavioral health needs of homeless youth and youth in foster care. Just a little bit about how we develop these recommendations. We listen really closely to the communities we serve and our community partners, and we base our recommendations on our experience providing legal supports to hundreds of children in foster care and working with communities to reduce homelessness, as well as feedback from children, youth, and their caregivers themselves. We also research efforts in other jurisdictions and gather input from Georgia-based providers, state agencies, courts, educators, and other experts. So this afternoon, what I propose is that we present information from 4 community partners, ourselves plus 4 other partners. The first is Javante Ford. He said he goes simply by Ford. And Ford aged out of the Georgia foster care system and directly into homelessness about 10 years ago. After his testimony, you'll hear from Ms. Glenine Lanier. Ms. Lanier is the Placement and Permanency and Placement Senior Director with the Georgia Division of Children and Family Services. She also happened to serve as Ford's case manager for a time while he was in care. So both Ford and Ms. Lanier can't be here in person today, so they're going to offer their testimony via pre-recorded video. Dr. Ailey Red is with us today, though. She's the Executive Director of Covenant House, Georgia, which provides housing and comprehensive supports for youth experiencing homelessness and escaping trafficking. And after Dr. Red, we're we're going to hear from Chad Jones, who's the Vice President for Business Development at Viewpoint Health, and he can offer the perspective of a community service board. I propose that I then follow Mr. Jones with some closing remarks and listing out some of the recommendations that we brought with us today. Dr. Red, Mr. Jones, and I would be available in person to respond to questions. So is that amenable to you, Mr. Chair?
That sounds wonderful.
Great. So before we hear from Ford, I do want to share a little context. My understanding is that subcommittee members prefer us to focus our time on pragmatic recommendations. And so in light of that, I'm not going to go through a lot of statistical or background information, but I do want everyone to understand where we're coming from. Our perspective is that there is an injustice in Georgia that we consider a fact, and that is that Georgia's children experiencing homelessness and children in foster care suffer from acute and chronic mental and behavioral health needs that just aren't met. So we're failing to adequately protect and provide for these children. And of course, the results are profound and tragic, and they're long lasting, and they have multi-generational effects. We do have faith, though, in the recommendations that we propose today. We think they're achievable, pragmatic, and they would make a big difference for these kids. So Ford is with us because his story really illustrates the dangers that these children face when they don't receive needed treatment and care. His story also, however, proves that if we provide children and youth with the mental and behavioral health supports they need, we can save lives and will alter the course of history for themselves and their families. He's going to describe how he entered care, how he was misdiagnosed with schizophrenia, how he didn't receive the needed mental health supports. And even though he was a good student, he exited foster care directly into homelessness, which prevented him from graduating from high school. But after he sought help and was properly assessed for his needs, he quickly passed his GED and moved towards stabilization. Now, his story isn't complete, but as you'll see from his testimony, he's quite capable of overcoming many of the challenges that adults created for him as a child. He just needs appropriate care and support. Ms. Lanierson going to emphasize that Ford's life would have been very different if he had received evidence-based assessments conducted by well-trained caregivers, trauma-informed care, and care that engaged multidisciplinary experts working closely together. In fact, he might not have entered foster care at all if we'd had more prevention policies to support parents in crisis. His mother struggled with substance abuse. So Ford's story illustrates the experience for thousands of kids in Georgia. His experience is far from unique. Children aging out of foster care, according to research, some 25% of them experience at least one episode of homelessness by the age of 21. Indeed, the homelessness has a tremendous impact on our school children. According to the Department of Education, in the 2021 year, which is the last year that we have data, almost 32,000 kids were unsheltered or precariously housed. So homelessness is something that's fairly common among our children. And homelessness and entering foster care, as everyone I'm sure here knows, are both traumatic themselves for any child. And they often will either cause or exacerbate existing mental or behavioral health challenges. And they instigate other problems too, like family and societal rejection, violence, emotional harm, discrimination. And as you'll see, our co-presenters will corroborate this, and evidence suggests that youth experiencing homelessness exhibit really disproportionately high rates of all kinds of mental health conditions: depression, anxiety, PTSD, schizophrenia, the list goes on. So the failure to both prevent and address the mental health issues that they experience, they result in larger sort of lifelong challenges. They enter the criminal justice system. While they're in school, they often have greater problems with school discipline, lower graduation rates, et cetera. And of course, not all populations are the same. So certain populations of kids experience homelessness and foster care at higher rates than average. So Black and brown kids and kids with disabilities, LGBTQ plus kids, they experience these at disproportionate rates, which perpetuate historic and systemic injustices. So we're going to present a number of recommendations to all of you today. I have tried to group them into some three conceptual categories. So first, you're going to hear us emphasize prevention, that Georgia should aim to ensure that children and their families have the resources they need to support emotional and physical well-being. So that gets to a lot of the social determinants that Dr. Lukowitz was mentioning. Second, Georgia should integrate community engagement and multidisciplinary collaboration at every stage of mental and behavioral health care. And third, we have to ensure adequate funding for prevention, high quality services, and a best-in-class workforce. So with that, what we'll do now is hear from Ford and then Ms. Lanier. Dr. Red will follow and Mr. Jones. And after their testimony, I'll wrap up by highlighting some of the specific proposals that Georgia Appleseed and our fellow panelists propose for your consideration. So if that is okay with you, Mr. Chair, what we'll do is I'll ask Ashley to queue up Mr. Ford's testimony.
I was 5 years old when I came into care. I know my mom, she was abusing drugs, but she was trying to get clean. But she wasn't doing it fast enough that the government felt, it was enough to keep the child in that situation. So the basic caseworker came to the house, tried to convince me to leave. But I remember closing the door in their face the first day. But the second day they came and said they were a friend of the family and asked me, do I want to go to Chuck E. Cheese? My first foster parent, I wouldn't say she was a bad foster parent. She just wasn't the most social foster parent. I grew up not really knowing much or doing anything, just doing the basic, going to school as a kid and then coming home. That lasted around to maybe 11 or 12, where I left there and I was in a bunch of different foster homes. Yeah, I just locked up because I was the type that I didn't really like to be around people a lot because I feel comfortable by myself. So I was diagnosed with schizophrenia, and I was given a bunch of pills like Adderall and a bunch of other, I don't remember, but they didn't really do nothing but make me feel horrible. Like they would help me focus, but it would be like I'm still hyper, but I'm sitting down. I didn't like it. It was like being a zombie. Because I know even when I was younger, the first things I was ever hearing about defects was, oh, they understaffed or they don't have enough people, so and so. So even when I did, the times I did see a caseworker, I never had them for long. Because I don't think I ever had a attorney just for me. And if I did, I was never contacted by one. I believe from 16 up, I was with a foster parent who she treated me like in-home help. Yeah, mostly I was there as a handyman. I was there to do stuff like cut the grass, whatever. I didn't mind, but I didn't like the consequence of no, I don't have to ward you in any way, do this or, getting close to aging out, so do this or get out. I got tired of hearing that a lot, and when I was around 18, she started piling up things that she wanted me to do. Like I started helping with roofing and tiling and stuff like that. And I was like, I don't want to do this, especially for free. Because if you're good at something, I always thought, at least you pay for it. But so I was like, nah, I'd rather be home than that. But she took that comment literally. So I ended up on this. School life always seemed much more peaceful than home life. So usually when I was at school, I would like to do something more like really relax. But still, I ended up completing school all the way to high school. But I wasn't able to finish high school due to being homeless. In one place, I was living on an abandoned playground. I know a few stores down, there was a mattress store. They whenever they got new stuff like new carpet, they threw out the old one. So kind of embarrassing, but I used to roll up the carpet and live beside those, but I didn't know it at the time. I was depressed a lot when I was little. Even if I wouldn't have took it, something simple is, do you want to help with this? Would have been great. I believe the best starting help could be mental health. I can only speak from my experience. I had the drive, just not the backing to do it. After I got with Hearts and Nourish Hope and I started getting my life back together, I went and got my GED. I passed that really fast though. If it wasn't for Hearts and Nourish Hope and Miss Nicole, who I met later on, she gave me the choice. She asked me, did I need help? In the past, usually that was code word for people that just want to be nosy. But once I was like, you know what, I actually do need help. But I'm glad I did ask for help because I'm going to be right here.
Thank you, Ford. We'd like to now hear from Miss Glenine Lanier. As I mentioned before, she's with the Division of Family and Children Services. And I just want to say on her behalf that she has agreed to obviously testify today, and the division authorized that. But I just want to make clear that she's expressing her own opinions and not necessarily the views or the opinions of the division as she does this. So Ashley, if you could cue up Miss Lanier.
Hi, my name is Glenine Lanier, and I serve as the Placement and Permanency Senior Director for the Division of Family and Children Services. And I served in this role for close to 2 years, and but I've been with the division for 29 years. At one point, I was Javante's case manager, and I worked with Javante and his family. And Javante mentioned his plight. He talked about some challenges that he experienced in terms of his mental health needs, having an appropriate caregiver who understood his trauma, the needs that he had regarding his mental health, his emotional health, and physical health, and that he feels or felt were somewhat unmet, which resulted in him being homeless for a time. And I will share that as a caseworker during that time, I remember having a caseload as high as 55. Many of the children that enter foster care have already suffered some type of trauma prior to entering care. And even with the child entering care, removals in and of itself can be emotionally traumatizing for a child. I think we oftentimes, as a system, misdiagnose children, or the assessment isn't appropriate because as the child is acting out, as a result, that child may be moved as a result of not having an appropriate or having a way to manage their feelings or their trauma in a way that we as adults understand what they're messaging to us. So as a result, that child could be moved to another placement, which compiles the trauma that child is going through with managing through another move. There are opportunities for us to try to maintain these kids in their homes. I think the Families First Prevention Act is a good step in the right direction for us to utilize an evidence-based approach. If we can't prevent a child from coming into care, when that child enters care, that child is connected to a caregiver who is trained and can appropriately work with the birth family and the child to successfully work that child either to reunification or to some other successful or positive permanency outcome for that child. There's an opportunity for us to look for a multifaceted or multidisciplinary way of working with families. DFACS is and should be one partner at a much larger table. We have the Department of Public Health, Department of DBHDD, DJJ, the school system, the court system. There are other resources and opportunities for us to collaborate, to work with these families prior to these kids, even after these kids come into care, for us to work together in partnership to appropriately manage supports, manage these families towards a successful outcome. And also just having a trauma-informed caregivers. Devontae mentioned his perception of what he experienced with his caregivers while in foster care, and feeling like he didn't have a voice in his overall case management. And I think that is still an opportunity for us, given the fact that we have such high turnover in the field, that we still struggle with having some casework continuity between children who remain in care for a very long time. Have the challenge of appropriately distinguishing between delinquent behavior that's truly mental health related, and behavior that's a result of some type of trauma that the child has experienced. I think we're struggling with that as an agency. Kids that can't effectively express how they're truly feeling, and so they act out in a negative way, and we have a response that's not trauma informed for that child. And as a result, that could be another move, or that child could be incarcerated. And I think that goes back to having an appropriate assessment, or having a skill set where we can connect to someone if we don't have that skill set, that we can partner with as an agency to adequately determine how best to manage the service array for the youth that we're trying to prevent from coming into care, or the youth that's actually coming into care. Working systemically to manage the mental health needs of both our children and our families is a step in the right direction for our agency, and would ultimately, I believe, result in youth being more successful, families being reunited, and could possibly reduce the outcomes such as what Devontae shared with us today. Thank you.
And thank you, Ms. Lanier. I'll say as a side note, I feel like Ms. Lanier's testimony really demonstrates that we should make it a priority to retain committed professionals and experts like Ms. Lanier in our state agencies, and how important it is to have that kind of knowledge and experience.
And the part that she said about not like he didn't feel like he had any control on what was going on. And it's very clear that working with this type of child, that if they're involved in their own care, the outcomes are going to be much better.
I completely agree. And I feel like that's a wonderful segue into our next speaker. Dr. Red, you'll shortly after the hearing, I think we'll distribute written testimony to everyone, and you'll have a chance to see her remarkable biography. But she is the executive director of Covenant House, Georgia. So, Mr. Chair, with your permission, I'll hand it over to Dr. Red.
Thank you. I really appreciate being here with all of you today. As mentioned, I'm Dr. Ailey Red, and I did have a slight title change. So I'm actually the CEO of Covenant House, Georgia. I'm also a licensed clinical social worker. I'm very happy to see Gleneen here and giving her testimony, because I've worked in social services in Georgia for over 30 years now, and have had the honor of working with Gleneen, not directly because I was a service provider and she worked on the side of the department, but definitely appreciate her testimony as well. But I do want to get into more about Covenant House, Georgia, and talking a little bit more about the concern that we're raising here. Covenant House, Georgia supports youth experiencing homelessness and escaping trafficking, ages 16 to 24 specifically. We provide emergency, short-term, as well as long-term housing, but we're much more than a shelter. We provide comprehensive services, including outreach, intensive case management, mental and physical health services, workforce development, and academic supports, just to name a few interventions that we work with young people. It is widely known that 50% of youth aging out of foster care will experience homelessness within 6 months. And 1 in 5 of those youth experiencing homelessness will be approached for trafficking within 72 hours. Youth aging out of foster care in Georgia and the youth supported by Covenant House, Georgia is in a very similar situation, unfortunately. I'd like to also thank Ford for his courage in sharing his experiences. He is definitely seen and appreciated, and much like many of the youth that we support here at Covenant House, Georgia. Like Ford, our youth have experienced and continue to experience challenges with lack of adequate support, mental health intervention, and experience trafficking, like in Ford's case, specifically labor trafficking. At least 40% of our youth experiencing homelessness and escaping trafficking experience moderate to severe mental health needs, especially in the areas of PTSD, major depression, anxiety, and attachment disorders. These needs are consistently not met for many years, if ever. And because of that, the lack of stability of placements and foster care, homelessness, and mental health challenges exacerbates the youth challenges when transitioning into adulthood and experiencing or trying to experience and reach self-sustainability. When the youth's mental health is unstable, they are unsuccessful engaging in education, workforce development, employment, healthy relationships, securing stable housing, and managing their physical health, putting them at risk for long-term instability and disastrous outcomes, including the lack of addressing their mental health. What I would like to do is offer a few suggestions or recommendations to be able to support youth like Ford. 1, support preventive mental health strategy, which includes stable, healthy housing, mental and physical health supports, positive learning environments, education, and workforce development can prevent mental health challenges that lead to these disastrous outcomes, which includes generational poverty that was mentioned a little bit earlier. 2, making funding for services easier to access by reforming state contracting procedures. For example, awardees should be notified of approval prior to the start date of the contract as to properly prepare for the program. Release funds timely to providers. The state, unfortunately, often makes payments months late in starting these as a result of starting these contracts late. Fund administrative oversight as far as indirect expenses, and fund at 100% of the programming costs, which decreases the burden on the provider to run the programs and fundraise to cover the gaps of the actual costs. 3, by increasing the timeliness of approvals and access to services, Medicaid wait lists and service times are shortened. Set the bar or expectations of approval times. 4, allow for in-home services and requiring collaborations and partnerships to form so that utilization of space and infrastructure, which is already built into their home communities, for example, utilizing spaces and partnerships like with the YMCAs, community centers, libraries, schools, etc. With proper safeguards, this will also increase access to services. 5, Emphasize family choice and community engagement, whereby the family should help identify their needs in partnership with the provider so that location, dates, times, and how best to deliver services focuses on supporting the family, the young person in the best way possible. Thank you very much for allowing me to have input here.
Thank you, Dr. Red.
Thank you, Dr. Red. And as a reminder for the subcommittee, Dr. Red is going to stick around. And so after the wrap up, we'll be available for questions. Obviously, we can take questions now too, if you prefer, Mr. Chair. Dr. Red's, again, her testimony, and so will Chad Jones, a report on their testimony will be included in our written testimony. So the recommendations that she just provided will be there. So next we have Chad Jones. Chad is a frequent participant and collaborator on these issues in Georgia. His bio is also in the written testimony, and he is the Vice President of Business Development at Viewpoint Health. So Chad, I'm going to hand it over to you.
Yeah, thank you, Michael, and thank you to you and Karen for this invite. Dr. Lukowitz, thank you for this opportunity and all you do with chairing this committee. Dr. McGivney, to you and Gwen, good to see friendly faces. Always love talking with you all about the challenges that we have going on. So as Michael mentioned, I'm Chad, Vice President of Business Development at Viewpoint Health. Been there for 20 years in that particular agency. Have done a lot of growth in that agency. And Dr. Lukowitz, I oversee all of our intensive community services, our criminal justice reform, such as accountability courts, all of our housing programs, and our youth and young adult services, specifically in youth and young adult, which gets us to the topic at hand. I have the honor and privilege of overseeing our statewide high fidelity wraparound program, which in the state Medicaid plan is referred to as intensive customized care coordination. We do a lot of work with families in that space around wraparound. Also oversee our school-based behavioral health project, which is known as APEX. APEX is a state program from the Department of Behavioral Health. We've grown that. I'm very pleased about that. We started with 3 clinicians, and now we have 28 clinicians in 41 schools. So doing a lot of great work in that. And I have a supportive education employment program with young adults, doing a lot of things in child welfare as well. At Viewpoint Health, we are a community service board, one of 22 community service boards operating as a safety net provider. We're going to mainly serve the uninsured, underinsured, low-income Medicaid, those types of things. We do a lot of services for veterans as well. Just to let you all know, we average a little over 16,000 individuals served per year, and we do we try to operate in a full continuum of care. So you can come into us at a crisis. No, there is no wrong door at Viewpoint Health. You can come in crisis access or walk-ins or anything you want to do. We're going to provide that. Try to provide that full continuum of care. You had mentioned SDOH, the social determinants of health. We actually do a lot of work in that space. Specifically, we are now kind of being graded on that, if you will, under a new federal grant we received, which is called the Certified Community Behavioral Health Clinic, CCBHC. It's a new model that the state of Georgia is going in for a lot of the community service boards. We're very happy to be part of that model. To the matter at hand, I have 6 key recommendations following up with what Dr. Red said. I totally agree, Dr. Red, everything you said was very well put together. Mine are going to start with this population that we're talking about is going to have trauma. And around trauma, there are 3 modalities that are probably the most beneficial, that have the highest efficacy. That is eye movement desensitization and processing, called EMDR. Dialectical behavioral therapy is the second one, referred to as DBT. And then trauma-focused cognitive behavioral therapy. They're not used as widely as we would hope throughout Georgia. So one of the recommendations is to open up training opportunities that are cost covered, because some of these trainings can get rather lengthy and expensive. Offer some more training opportunities that might have some cost coverage, or people that can kind of buy in at different levels and things like this, to basically broaden that training out. Next, Number two on this list is really look specifically at the psychiatric residential treatment facilities and the child care institutes. So for the psychiatric residential treatment facility, the PRTFs, there are 6 in Georgia, you all know. The majority of them, high majority of them, actually take individuals, they serve kids from out of the state of Georgia, because they need to fill those beds for obvious reasons. They need the revenue for obvious reasons. What happens is when those beds get full, you have situations in child welfare. Well, child welfare may need those, and they end up hoteling kids. And we all know what that term is, hoteling. The last report that we received is that Georgia has always fluctuated in the 70-ish mark for hoteling. Judge Juanita Stedman had reported in another group that I chair, Dr. Lukowitz, called the Georgia Alliance for Therapeutic Services. I've been the chairperson for GATS now for going on my 3rd year. It's an honor to do that. She had shared that we're over 100 now that are hotel. So the recommendation here is don't just throw a regular per diem rate at a PRTF and say, here you go, can you serve the kids? These are kids that need creative programming, more intensive type programming. So the idea is could you add some more flexible funding, and could you look at that rate that would make it more attractive for a PRTF? Say, hey, look, we're in this business to serve high risk kids, and this is one, but we can't go in the hole and really hurt ourselves in trying to make it work. They're going to need that increased and flexible type funding. So that's number 2. Number 3, well, we've seen a lot, Dr. Red. I don't know if you've seen it, but we have definitely seen this in the last 4 to 5 years. It used to be in the old days, someone would say, oh, they're dual diagnosed or co-occurring. And that meant mental health and substance abuse. That was the co part. It is now, over the last 4 or 5 years, we've seen a huge shift of there is co-occurring as mental health with a developmental delay or developmental challenge. So our recommendation there is we're actually getting our foot into that pool. Just to let you all know, we're doing some exciting things around that dual diagnosis of mental health and developmental disability. But we're having to go out there and kind of piecemeal and pull different parts together and kind of learn from ourselves and call other people that may be in this work. But we really need a short-term work group. I'm not saying it has to be a work group that's established a committee forever, but some type of work group says, hey, look, let's really look at this. I was in a testimony recently in a court hearing with Dr. Dustin Hall from Georgia Regional Hospital, mentioned the very same thing. He said in the last 3 years, he's had more young ladies that have a developmental challenge that are swallowing things and using that as self-injurious, but they have a developmental delay, and there's nothing to do. So we really need a work group, somebody to really focus and say, hey, where can we put some strategies around this? Number 4 I have on the list is really leverage what's already out there, and specifically I'm referring to the multi-agency treatment for children, the MATCH committee. I was pleased to serve on the 3-month strategic planning team with Gwen around MATCH and try to basically answer the question, well, who is MATCH? What is MATCH going to do? But we've actually had some real life examples of what I'm describing of high-risk individuals. This was a true young lady that was on her way to be hoteled. She is involved in child welfare. They had reached out to other states. Other states had said no. And then it worked its way to the Department of Behavioral Health, and it was a MERA group, Georgia Families 360, doing a per diem. It was DFACS doing a contract with us for some supplies and other types of things we need. It was DBHDD allowing us to do certain things, and we did it. We changed some kind of rules around the system of what we could do, and we were able to serve her. And now she has stepped down and is in one of our group homes and doing very, very well. That is an example of leveraging a treatment team together and braiding that funding. We need the braided funding coming together. And everybody kind of threw a piece in the pot. And now that young lady is 19 years old and is doing quite well. Number 5 recommendation I have is really look at some other things that's already there. Under Medicaid, there is an EPSDT clause, which is early periodic screening, diagnostic, and treatment. What we're looking at there specifically is the S part of that. EPSDT, it can only be authorized right now in Georgia for pediatricians. We as mental health providers can do the diagnosis and we can do the treatment, but it's the screening piece. And what I mean by that is, and Dr. McGibney, I don't know if you remember this, you came out years ago to Gwinnett County when we rolled this out, and you actually met with our team in one of our schools where we go into the schools and we do screening. We could expand that. Other providers could do that. We do it right now with Gwinnett County because Gwinnett County actually pays some for it. But there's no way for us to actually bill the screening mechanism. We have to, you're either going to do that as a pro bono, using Michael as a lawyer, using your terms, pro bono there, or you're going to have somebody else fund it. But if it was open up where an LCSW could come in and say, no, I'm going to authorize this screening, then we could actually screen the children, specifically those in foster care, and find out a better path of services. Just to let you all know, to give a number, we average about 800 a year in Gwinnett schools around the screening. My last recommendation, and I'll close with this, really mirrors what Ms. Lanier said around Families First Prevention and Services Act, the Families First, short, we usually call it Families First Act for short. And it's really using that Title 4E funding to create more opportunities for reunification. Well, in the child welfare system, you all know this, in the child welfare system, you go down a path of either non-reunification or reunification. If you're in reunification, you could be in a program called family preservation. In that space right now, DFACS has to currently pull in providers, and all those providers have to get authorized on all the services, even if the issue is the parent. And let's think about it. How many times have y'all been in a meeting? Dr. Red, you know this to be true as well. How many times have you been in a meeting that people say, yeah, the kid's got an issue, but the real issues are the parents? Well, the things that with this act, it allows you to use that funding for whole health and whole family treatment. So you can provide services to the family member without having to get them authorized and diagnosed and the whole things that would have to happen now currently in a system to get them in to seek care. Now you can provide services for the whole family under this. So DFACS is working on that. The division is working on that. My recommendation is we need a little bit more urgency with that. They're creating a clearinghouse of different modalities they want to use, different treatments. But we need to kind of get behind that, maybe push out a little bit, because there is an opportunity to do whole family care as it relates to child welfare. So those are my 6. Dr. Lukowitz, again, great to meet you for the first time.
Nice to meet you as well, Chad. That's very exciting to hear about all this stuff, because I learned last year there's a lot of really good things going on in Georgia, except it's just not going on everywhere. And so I've had this discussion with Commissioner Tanner, that if we could expand all these phenomenal programs across the state, we wouldn't be in the boat that we're in today. Another thought was, you talked about the co-occurring developmental disabilities, and a lot of that is autism, because that's exploding. And it's very clear that autism in Georgia, clearly, if you look at the laws, was an afterthought. And they just saw these people coming up, getting diagnosed, and they said, oh, we need to do something about it. Well, we have a very, very nascent population of providers for autism, with the number of RBTs and BCBAs is woefully inadequate. The wait lists for applied behavioral analysis is just, in some places, for years. I mean, it's in where we are in Augusta, it's I have a 5-year-old who's been waiting almost a year to get into services, and on like 4 different waiting lists. So this is one of the few things that are the services that we have to offer, despite the fact that we have the Marcus Institute and the Emory Autism Preschool, and they've got a clinic there as well. We're just not as good as even our neighbor in South Carolina. So I'm hoping that will be a big focus going forward, because you can't separate. And this is one of the problems with what's happened. We separated mental health, developmental disabilities, substance abuse, and physical health. That doesn't work. That's an artificial construct that is not based in reality. And as long as we continue to do that, we're not going to get anywhere. So other questions?
A comment, not a question, because I agree with all of the recommendations that were made by Dr. Red and Chad. I do think that we need to incentivize providers that network together to provide services, because I think it increases stability for the system. And so it's one of the things I would like to see happen as a recommendation is that when we there are some things you can do by yourself. And full disclosure, Chad and I are working together on a project for those co-occurring kids, and it just feels so much better to be working with a partner on it and knowing that we can grow it more easily than just depending on single providers to come up with the answer to everything. We need continuums.
And Dr. Lukowitz, I do have a question for Dr. Red. The Covenant House, those programs are statewide.
Covenant House, Georgia is actually located in the city of Atlanta. We're located in Northwest Atlanta. Most of our support services are located in the metro Atlanta area. However, we do, as a part of our next 3-year strategic plan, is to be able to assess how we can support across the state in a more broad way. But we have been doing some partnership work and some outreach down in the area.
And thank you for that. And I like the idea that you're thinking about how to expand statewide, because what you're doing is needed, obviously, in so many places. How are youth referred to you?
So our youth come to us in so many different ways. The primary way that our youth come to us is that they recommend each other to us because they trust us. But we also have a street outreach team that goes out and combs the metro area, the streets, to build relationships with those youth experiencing homelessness so that they will trust us and come in to receive services. But we have referrals that come in from school systems, homeless liaisons. We have youth that may have been incarcerated, and so we'll have probation officers or parole officers dropping kids off. Sometimes young people are aging out of foster care, and so unfortunately, we've had some situations where DFACS has dropped young people off, and we are working with the department that does not occur. But school systems, places of worship, board members, concerned community, providers, partnering organizations, it really runs the gamut of how young people come to Covenant House, Georgia.
Thank you.
Yes.
And Chad, do you think the CCBHC model addresses some of the issues that you're facing and some of the recommendations that you have articulated?
It addresses some, as if you think of my recommendations like ingredients in a cake, Dr. McGivney, and that's the only thing I can think of right now because I'm hungry. So I'll go with food. I'll go with food. The CCBHC is going to be that bowl that you're going to stir everything together and try to get it. So you heard Gwen talk about we need people working in a collaborative way to create a continuum of care. Well, CCBHC has that built in. It actually has it even at a legal standpoint called a designated collaborating organization. So you have to collaborate. You have to show how you're building a continuum of care. That's one. Two, we talk about access points, and are you looking at the need in the community? Well, at CCBHC, you have to do a needs assessment, and it has to be an outside party that does it. We just finished ours, and it's extremely exhaustive, not exhaustive in a bad way, just quite cumbersome and quite detailed about what this needs assessment looks like. And so what you do based on that needs assessment is then you are going to gear that programming for that, which is where we have the DD situation that's come up. And you have to create around there a no wrong door entry. So there's not, well, we're going to create this, but you have to fill out this form and we have to take this insurance. You can't refuse anybody for failure to pay. So it covers a lot of the stuff we talk about. I wouldn't say it is one of the ingredients that you throw it in the pot. It's the pot that can hold all this, if that analogy holds any weight.
Well, that's a great analogy, actually, for several reasons. How many CSPs are adopting the model or working with the model now?
Right now, you're at half. There's 22 CSBs in Georgia, and there's 11 that have CCBACs. Of the 11, 4 of the 11 have a state grant from the state, from Department of Behavioral Health, that basically DBHDD pulled down and gave out money to the state. So there's 4 of those. The other 7 are SAMHSA, and you obviously know that acronym, Dr. McGivney. So SAMHSA is doing those federal grants. All the grants right now are pilot demonstration grants, meaning that you are doing all this, getting things built, and attesting that you're working on these things so that you can get certified. The idea is to get certified in the final year of the grant. So just in case you were thinking, well, how many are certified at CCBC? Nobody is right now. Everybody is in that demonstration phase.
And once you're certified, does that open up grant opportunities?
It opens up something called a PPS, and that's a new acronym that we all love. And a PPS is a prospective payment system. So you add in all your true costs. So all that cost I said that, if we have a coordinator that goes out and does this collaborative work, as Gwen said, we need to incentivize this getting together. Well, if I have a coordinator that's doing that, Dr. Lukowicz, you mentioned it very clearly. We've got too many silos, and we've got this physical health and mental health, and the never two talk. Well, the CCBAC, we have hired a care coordinator that's all they do is focus on physical health, right, and those appointments of how they relate to the mental health. So we're doing that, but the grant pays for it right now. When the grant is done and you're certified, you are into a new payment system, a prospective payment system where you get paid your true cost. So we add all those salaries and all those outcomes that we're getting, and what did it take to get that outcome? What was that cost? And you get paid on that true cost.
That sounds like a great idea.
Yeah. Yeah, it's a huge movement. Of course, I've mentioned there's 11 in Georgia. We have a whole collaborative. We meet. The DBHDD has a consulting firm, which actually we meet every other week with the consulting firm. They're called MTM. They work directly with the National Council as well. If you were to, and that's Georgia's. If you look across the nation, there's over 300 sites. By the year 2025, they want to have 500 sites nationally is their goal. They being SAMHSA and the National Council for Mental Wellbeing.
One more question, Dr. Lukowicz, for Chad, is that with the CCBHC, where does the school system fit into that model?
The school system fits into the model. However, in your demonstration grant, however you wrote it, so I can speak for us. I actually wrote part of our school-based behavioral health work in that screening piece that I referenced earlier. I wrote that into part of our grant. So our chief clinical officer and I and our CEO, Jen Hibbard, who's fantastic, huge supporter of the work. The three of us kind of collaborated with of course, our CFO, Dr. McGivney, as you know, has to do all the budget piece. So in our demonstration, we actually wrote that in there, but we focused it on integrated care. So that physical health piece, and are we getting those kids screened for health care and the dental? Are we doing that right? Are we coordinating with that care? And Latino. So we looked at the bilingual piece. We have a bilingual clinician that's with us working in the CCBAC. So it just depends on how you wrote that grant, the demonstration grant. Once you're certified, then those services become like everything else. You know the whole access point. But in our demonstration, we specifically hit key parts that we're looking at.
Thank you, Chad.
Yes, sir.
Chair, we have some additional recommendations that might spur additional conversation if you want me to share some of those. And again, I'll just remind everybody, you'll get a copy of the written testimony, and you'll have all this information so that you can look at that again in more detail. And in the policy recommendation, in the written testimony, there's, like I said, more detail, but there's also reference to some other organizational partners that you're all aware of, but that do a lot of good work in this area. So particularly Voices for Georgia's Children and the Carter Center Mental Health Program in Resilient Georgia. We partner with them in a collaborative around behavioral health for children. And so I linked to some resources there as well with some policy recommendations. As I mentioned before, we try to group these into 3 main kind of categories. The first is expanding prevention efforts. And some examples of that Chad touched on, but expanding school-based mental and behavioral health services. For the work that we do, this is really critical. The kids that we see are kids who are in crisis in a school discipline matter, DFACS refers children in foster care directly to us when they're facing long-term suspension or expulsion from school. And I don't have a percentage for you, but I would say the vast majority of kids have some kind of developmental disability, learning disability, or a mental health challenge that affects their classroom behavior and performance. And the result of not receiving support and services for that is pretty profound. Immediately, obviously, it can instigate school suspension, but that also often will precipitate like a home placement move. Once the kid can't be in school anymore, foster parents can't take care of the child because they work, and the child has to be moved again. And you just see this effect that Ms. Lanier talked about, where you have this sort of compounding, negative, initial trauma, and then compounding adult behavior, essentially, that causes more and more problems. So expanding and investing in school-based mental health for every child in Georgia that needs it. Also, Georgia has a long and significant commitment to positive educational learning environments, so school climate reform and evidence-based programming for that, such as PBIS, and the state needs to completely commit to that. That's our recommendation. That changes the school environment to be a nurturing school environment and reinforces protective factors, mental health protective factors for kids.
Yeah, I have a friend who knows a little bit about school climate.
Yeah, he may be on the.
That's right.
Yeah, I'll just tell a joke. At one point, I was talking to him and he said, "I don't want to put words in your mouth." And I said, "About school climate, you pretty much every word that comes out of my mouth." Another, something that we're very interested in is the trauma impact rule. This is a new law in Georgia that was passed a few years ago that requires every school to do a trauma impact assessment for every child in foster care to determine the impact of trauma on their classroom behavior and performance. That its impact should be assessed. We should determine how well it's working, and then think about amending that law to extend it to cover additional students, particularly children experiencing homelessness. And then Chad mentioned, of course, opening up screening, making it easier for other professionals to use and bill for it. I want to reinforce what I think it might have been Ms. Lanier, or maybe Dr. Red, you said this, but expanding tools for DFACS like respite care, expanding respite care so that when there are families in crisis or they need a break from children with behavior challenges, just to kind of maintain family integrity, there's a place to do that temporarily. And also thinking about therapeutic foster care and the role that it plays in not providing care in a home setting for kids with complex needs. I think the state should also focus on transition age programming and look at establishing a strategic plan, a multidisciplinary, multi-agency work group to look at the program that we have right now. There are, within the nonprofit community, with the partnership, DFACS partnership, there is a program right now looking at that, a cohort, and that needs to be a priority. Also, expanding housing supports. I mean, we all know this. Housing is a major barrier to mental health for children. And there are some policy solutions out there. For example, there's a federally funded foster youth initiative voucher that's highly underutilized in Georgia, and that should be studied. We should find how we can better utilize tools that already exist. The second conceptual area we talked about was emphasizing community engagement and collaboration. Chad talked about the match committee, the revitalized match committee, and leveraging that. I also want to talk about on the local level, something that's also near and dear to Dr. McGivney's heart, and that are school attendance and school climate committees. These are statutorily mandated. These are required by law. Every Superior Court is supposed to convene one of these committees. And our research, which we've been doing over the last 2 years, to determine where they're happening and how well they're doing. Very, very few counties are doing this. And what's significant about these committees is they can be a place where you can coordinate prevention strategies and practices across the schools, the courts, the police, and other stakeholders to support children and youth in crisis. They're an opportunity, they're already required, and so incentivizing communities to invest in those and to convene those. Also, as Dr. Red pointed out, prioritizing the delivery of timely services in home or in the field, finding out where is the best place for families to receive services and asking them, engaging them in the process, going to communities and say, where is the best place for these services to be received, whether that's at home, in school, as Dr. Red said, in local YMCAs, public facilities. And then Also emphasizing that there are services that are underutilized, like Georgia's mobile crisis service. 24-hour immediate on-site crisis management. You access it through GCal. Dr. McGivney was telling me the other day that he's talked to school districts and they don't even know it exists. And so increasing awareness about some of these tools would be really helpful. Also using data to enhance collaborative efforts, prioritizing the use of data and sharing of data where appropriate among agencies and with communities to make sure we're collaborating and doing it well. And the third conceptual category is leveraging funding opportunities. Chad mentioned the Families First Prevention Services Act. I think Dr. Red did too. This is really important. And we need to put additional urgency on making sure that we get those resources and we're using those resources to protect children from entering foster care at all, and also supporting that family integrity. Also increasing funding and reimbursement rates for case management, PRTF, CCIs, Medicaid, and other necessary services. Chad talked about this. Dr. Red talked about this as well. What I want to just briefly talk about is thinking about funding for DFACs, for case management. I just don't think this can be said enough. Our children are not going to receive the care they need if there isn't case management, sufficient high quality case management. At this point, last year, I think DFACs case managers, 55% of them left their jobs. They start with a bachelor's degree at about $40,000 per year. This is based on my research looking at job listings. And some other caseworker doing critical functions may start as low as $33,000. And so adequately funding our case management services, improving compensation, improving retention is just fundamental to this effort. And it has to be a #1 priority. And then as Dr. Red pointed out, looking at our policies, our contracting policies to make sure that our providers are reimbursed in a timely fashion. That's a major obstacle to care. And then exploring new sources of funding. Chad mentioned some of these. Other jurisdictions are experimenting with things. For example, Oregon has a Medicaid waiver that funds housing supports to populations in transitions. So there's some research that could be done. We're happy to help with that, to look at other types of other sources of novel sources of funding in Georgia. So that concludes my part of the presentation. We're here for questions. I just want to take a moment to thank you all for the opportunity to share these recommendations today. As you can tell, all of us are extremely passionate about this, and to be able to talk and talk through some of these recommendations and share them with you in written form is a real privilege. So thank you.
And it's pretty clear that the recommendations that are being made are well thought out and has taken a look at what's out there and what's been successful. So, I mean, it's just a matter of getting the people behind the money to see the importance. And can sometimes be a challenge, especially this past year. I'm much more optimistic about this next legislative session, but keep my fingers crossed. Other questions or comments? Well, this has been very eye-opening for me, and I'm sure other members of the subcommittee. And I appreciate the efforts that y'all are putting forth to making the landscape for children and adolescents better in the state of Georgia. And I'm optimistic about the future. We know what we need to do. Now we're figuring that out, and we just have to start moving forward and doing it. Well, thank you so much. And again, I appreciate you all showing up and giving us these insights and recommendations, and we will share them with our peers. Thank you. Thank you.
Thank y'all so much.
Have a great evening.
You too. Thank y'all.
Thank you.
Bye-bye.
Thanks. Bye-bye.